Sir, good evening. Kabra, sir.
Yes.
It's 4:03. I can start in 2 minutes. I'll just today Sunil Gavani is busy with some emergency in the department. So on behalf of the state chapter of NNF, or the Maharashtra State NNF, we welcome you all for this week's webinar. We are very happy to have Dr. Nandakishore Kabra sir, who's here to moderate the session. We all know sir for his teaching, and basically he has been the force behind all of us to spread education, knowledge and good practices in the state of Maharashtra. So welcome sir.
Thank you.
Today's topic is a bit different. We are going away from the glamorous neonatology to know the reality of what we are doing right, left and center. And when we ask ourselves that we are very happy to have saved a 600 gram or a 500 gram baby, what happens to these babies in the days to come? We are not only interested in saving the baby or being happy after survival, we also want the babies to have intact survival, and that's why we need to know how do we assess the outcome of these babies, because at the end of the day, what happened to these babies at 2 years or 5 years or 10 years, and we have seen from the developed world the long-term outcomes of these children who are born below 28 weeks and below 1000 grams, and these outcomes necessarily have to be good. And to have this insight into this aspect of developmental outcomes, we have with us Dr. Archana Kadam, who is a developmental pediatrician, and she would enlighten us to assess the babies, what is it that she does in her practice with a case-based approach. So I now hand over the proceedings to Dr. Nandakishore Kabra, sir. Over to you, sir.
Thank you, Sandeep. So Archana does not need an introduction. She is a very well reputed developmental pediatrician, and I know it's very difficult to get an appointment for months together in Pune. She is MD Pediatric, DNB Pediatric. She is currently affiliated with Jahangir Hospital and KM Hospital, and she is also actively involved in neurodevelopmental assessment from research perspective, also looking at how these kids are doing, and in the process of publications also she's way forward. So without wasting much time, I hand over the proceedings to Archana to start with her presentation. Thank you.
Thank you, sir. Good afternoon, everyone. Are my slides visible?
Yes.
Yes.
Thank you. Now, my topic for today is developmental follow-up of newborns in office practice, and our aim is to look at it as a case-based approach. Now, neonates who are in the NICU, by virtue of their course in the NICU, are at risk for a lot of developmental disorders. One is developmental delay. This can manifest as delayed milestones. Sometimes it's just speech delay, sometimes it's speech clarity, and at a later age, they can have academic underachievement. Motor difficulties can manifest as tone abnormalities, delayed motor milestones, cerebral palsy in some children, developmental coordination disorders. So those are the motor deficits that we could see. Sensory impairments can be vision, hearing, and sensory processing disorders. Sometimes we can have children whose cognition is good, but they may have specific difficulties in reading, spell, or math. That is a learning difficulty. And behavioral issues like ADHD, autism may also be common. Now, let's look at, when we do developmental follow-up, some common terminologies that we use. Developmental follow-up is the serial longitudinal follow-up of children with treatment for emerging ongoing problems. Developmental screen is a brief test to pick up which child needs a more detailed evaluation. Whereas developmental surveillance is the longitudinal monitoring of high-risk newborns in children who are at risk for developmental disorders. Now, why do we need to do a developmental follow-up? We know that the first years of life are crucial for lifelong learning and development. 80% of the baby's brain is brain development is complete by 2 years. So if we can pick up a developmental disorder early and intervene early during the period of limited malleability of the brain, the baby or the child is likely to have better functional outcomes. Why does it need to be periodic? Because development is an evolving dynamic process. So if you see the child just once, you're getting a snapshot of the child's development, and the disorders may evolve, which is why we need to see children periodically. Now, how do we go about screening in India? Now, we tend to divide children into those who are at low risk for developmental disorders and those who are at high risk. Children who are at low risk need to be seen at 9, 18, 24, and 36 months with a mandatory autism screen at 18 and 24 months. However, children who are at high risk for developmental disorders, like our NICU graduates, need to be seen once between 3.5 to 6 months, 3 monthly till 1 year, 6 monthly till 3 years, mandatory autism screen at 18 and 24 months. And these children need to be seen even after they enter into school annually to look for emerging academic attention or learning issues which could emerge at that time. So which newborns would we classify as low risk or high risk? As per the course that the newborn has in the NICU, we stratify children into mild, moderate, and high risk. So a high risk baby is one whose gestational age is less than 28 weeks, less than 1 kg, who's had APGARs less than 3, persistent prolonged hypoglycemia, meningitis, severe bilirubin encephalopathy, IVH, twin-to-twin transfusions, ventilation, babies who have surgical problems, babies who have genetic problems, metabolic problems, and also babies where parents have a concern about the child's development are considered to be high-risk babies. So if you have a baby who is mild risk, this baby can be followed up as per our low-risk protocol. Whereas if the baby has moderate or high risk, this child will follow our high risk and needs to be screened accordingly. A baby who has mild risk can be seen by the pediatrician, but one with moderate and high risk needs to be seen by the neonatologist or a developmental pediatrician. Now, let's look at case 1. This is a newborn baby, 32 weeks, with a birth weight of 1485, had premature rupture of membranes. There was no ventilation. There was routine NICU care given with no major events. So this baby is stratified as moderate risk for developmental delay. How then would we go about identifying developmental disorders early in this baby? One tool to identify neuromotor difficulties right away in the NICU is the General Motor Assessment, the GM, which was devised by Prechtl. Now, this is a non-intrusive assessment where you just watch the baby's movements with a video, and that helps you pick up a child who's not developing neurodevelopmentally doing well. Now, normally a baby in utero around 7.5 to 9 weeks starts having movements. Now, these movements of the baby are generated by the central pattern generator, which is in the medulla oblongata. Now, as the baby moves, sometimes if there is an insult to the growing brain, the pattern in which the baby moves can change. And if we can train ourselves to look for the pattern to see whether it's normal or is it a deviation from normal, we are able to identify children early. Now, in a baby who is in the NICU, a preterm baby or a term baby till 6 weeks has 4 types of movements which are possible. One is a normal movement, which we'll be seeing in a bit. The other, if the baby is not moving as well as he should, it would be with a less variability. We call it as poor repertoire. The other abnormal movements are cramped synchronized, which can predict cerebral palsy very early, and rarely chaotic movements may be observed. Now, what we'll do is we'd like to see how a normal preterm baby moves. Now, whenever we are looking at a video, it's important to remember that this video is short. You're not stimulating the baby to move. You're waiting for the baby to show spontaneous movements. Whenever a video is to be played, this video always needs to be muted. Why do we mute it? We mute it because we don't want auditory distraction. We want our focus on visual perception to see how the baby moves. So we have this baby, the 32-week-old, whom we are seeing now at 35 weeks. Can we see the movements now? Now, if we have a look at how the baby is moving, we see that the movements are variable. They sometimes start in the hand, then they spread to the other hand. Then you see the trunk movement. Now they're spreading down to the legs. The movements are variable speed, variable amplitude. They start gradually, they end gradually, and they are beautiful, elegant movements. A 35-week-old baby, when it moves, has a bigger amplitude of movement. In contrast, a 40-weeker, the movements are closer to the body. So if the baby is not moving, we will still wait for the baby to demonstrate the movement. Here you have beautiful, elegant movements with rotation of the trunk and rotation of the pelvis. It's telling us at 35 weeks, this baby is moving normally. In contrast, if the movements are such that they are poor in variety, they are starting abruptly, ending abruptly, and they are not elegant movements, and the same pattern keeps repeating, we would call it as a poor repertoire movement. At 35 weeks, we can have normal or we can have PR. We then see the baby again at 40 weeks. And at 40 weeks, what we can see is a normal movement, a poor repertoire, or a cramped synchronized movement. Now, as the baby grows older, between 6 to 9 weeks, you will have rhythmic movements. So that's the age we don't look for GM movements. After 9 weeks, the baby starts developing what are called as fidgety movements. These are small oscillatory movements that happen in the wrist, the elbow, the shoulder, the pelvis, and that gives the baby a fidgety or a bouncy feel. Along with that, the baby starts developing spontaneous voluntary movements, which may be midline activities. We'll see that in a bit. If the baby doesn't have fidgety movements, we would call it as absent fidgety movements. And sometimes the baby's movements are so rapid, which are ragdoll, we call those as abnormal fidgety movements. So 9 weeks onwards, we have 3 GM movements to look for: normal fidgety, absent fidgety, or abnormal fidgety. Now let's see this same baby at 16 weeks. Again, mute the video and start to see it. Here, what you're seeing is tiny oscillations in the wrist. You see them in the elbow just now. You're seeing it in the wrist again. You're seeing it in the pelvis. There you go. And you see an excitement burst in this baby that gives the baby's movements a bouncy feel. So fidgety movements can be picked up within 5 to 10 seconds of start of the video. What you're also seeing is spontaneous movements. You have a leg lift, you have foot to foot, you have hand to hand. So these are beautiful midline movements. You're seeing trunk rotation, you're seeing this baby focusing, looking at the surroundings, showing excitement. That's an excitement burst. This is a hand to mouth. So what we do is we look for fidgety movements and we score these midline movements and the movements that come up, the swipes or the kicks, and we obtain a motor optimality score for a baby. Now the motor optimality score of this baby is 28. The highest score that the child can get is 30. Now the score is not important, but it's important to remember that if the baby is moving as beautifully as this baby is doing fine neuromotor. In contrast, if the baby's fidgety movements are not visible, nor are there any midline movements, the baby would score lower on motor optimality score, and a score less than 23 generally warrants starting early intervention at the earliest. So we can have, we've seen our baby, our 32-weeker at 35 weeks, where the baby's movements were normal. At 40 weeks, the baby continued to have normal movements. And at 16 weeks now, this baby has normal fidgety movements with a good optimality score. We know that this baby is likely to do well. Now, let's look at GM trajectory. Now, if we see the blue line on top, we have normal movements, 35 weeks normal, 40 weeks normal, baby moves ahead and develops fidgety movements. In contrast, if the baby has a PR, this PR can normalize at any time and become normal. The PR may continue to have absent fidgety or may become normal. The cramp synchronized is the one which may come up in a child who has a prediction for a spastic cerebral palsy. The earlier the CS comes to PR or normal, the better the baby is likely to do. So do a GM at 35 weeks, at 40 weeks, and preferably do one around 12 to 16 weeks to help us predict better. So how sensitive is the GM? The GM is highly reliable. Specificity is 82 to 99% and high sensitivity of 95% to 100%. The GM can identify cerebral palsy as early as less than 5 months. A cramp synchronized is 97% predictive of spastic cerebral palsy. So if we can identify early, we start intervention at the earliest. A GM, the predictive power is superior to an ultrasound or a neurological examination in the newborn and equivalent to an MRI. We need to supplement the GM by doing a neuromotor assessment around 2 to 3 months. We could use the Hammersmith, which can be used between 2 to 24 months, and Hamilton can be used till 1 year, where you see for the head size, active passive tone, evolution of primitive reflexes, and emergence of postural reflexes. So the best way to predict a neuromotor abnormality is to do GMs in the neonatal course till say 4 months of age and supplement it with a neurological evaluation. That's how we would be able to pick up the babies at the earliest. Now, in addition, when the baby comes to us for follow-up in our office practice, we are going to look at red flags for motor milestones. Now, a red flag is an age at which 90% babies of corrected age tend to achieve that milestone. So if the baby is not doing what a red flag is saying, this tells us that this is a child whose development needs to be screened. A red flag is not a formal screening or a diagnostic tool. So coming to red flags for gross motor skills, if a baby is not having good head control by 4.5 months, it's a red flag. If he's not able to roll over by 6 months, red flag. If the baby is not able to sit without support by 9 months, if he's not walking independently by 15 months, red flag. If he's not able to do the stairs, both feet on one step with support 2 years, red flag. Other red flags, if the child is not able to jump with both feet off the last step by 2.5, red flag. If the child is not able to pedal a tricycle by 4 years, it's a red flag for motor milestones. If the child is sitting in this posture demonstrated, W sitting, it's a red flag. If the child, while getting up from sitting, climbs on himself, Gower sign, red flag. Toe walking, red flag. And in an older child in school, if the child is left out of sports because he is clumsy and just can't hold the ball, it's a red flag. Loss of motor skills at any age is taken as a red flag for a motor problem. Coming to fine motor, how the baby uses his hands. If the baby is fisting by 3.5 months, if he's not holding a rattle, if he's not able to transfer from one hand to the other, if there is no pincer grasp by 11 months, if the baby is not able to hold a crayon and is not able to initiate a scribble by 12 months, if the baby is not able to put objects in and out of a tub by 15 months, red flag. If he's not able to do a scribble on paper by 2 years with a palmar grasp, red flag. If he's not able to imitate shapes like a copy, a circle by 4 years. Most important, if the baby less than 1.5 years is using only one hand, it's a red flag for weakness in the opposite side. So that is how we would go about a follow-up of our case 1, where we found this baby was doing neuromotor okay, cognitively the baby was doing okay. So we predict that it is likely that this baby is going to do well even at a later age. Let's see another baby. This is a 33-week-old with a birth weight of 1380 grams. History of sepsis and meningitis causing a prolonged NICU stay for this baby. 35 weeks, baby had a PR. 40 weeks, this baby had cramp synchronized, which we were able to pick up and we started intervention. The same baby at 12 weeks on GM had absent fidgety and no emergence of midline activities, and an amyl saw done at 12 weeks suggested increased tone. So this is a baby where we would start intervention at the earliest. The earlier we start, the better the functional outcome of the child. So coming to early intervention is a team multidisciplinary effort. The aim is to empower the parents to help use strategies at home. The focus of early intervention for motor problems, the focus has now shifted from passive stretching to active involvement, where the aim is on problem solving for the baby using attention and motivation as key factors. So the parents for such a small baby would be taught correct patterns of keeping the baby supine, prone, facilitating a rollover, facilitating reaching for objects with visual and auditory stimulation. Now, let's just look at some correct postures to carry the baby. Now, here we have a therapist holding the baby. Now, in this posture, the tonic labyrinthine reflex is reduced, the hips are flexed, the neck gets flexed, the hands are free. The same posture is taught for the mother to do at home. That is tummy time, where we are seeing that we are facilitating the emergence of the Landau, and we've kept a toy in front, a visual stimulus, so that the child learns to reach for it and thereby facilitate a correct pattern for prone. Sitting posture, this is a correct sitting posture with the back support, hip flexion, the head just comes the right amount ahead and the hands stay free. This is the feeding posture if the baby is in the mother's lap. Again, there is back support and hip flexion. And this is a feeding posture for a baby in the chair, where you can feed from the front. Midline activities facilitate best learning. Now, the therapist tends to use multiple approaches. One is to empower parents to have correct postures. and also set goals for the baby. Say, for example, we want a baby we want to motivate the baby to hold on to support and walk. We would keep a toy on a chair so that the baby makes an effort to try to reach for it. As the baby stands, we would try to implement strengthening for antagonistic muscles, have better gait and better balance or posture. So this is the aim of early intervention. This is the dressing posture where you put the baby across the mother's leg. When we do that, we are reducing the tone fluctuation in the upper limbs and facilitating writing. So as far as neuromotor follow-up goes, we start by trying to pick up as early as in the NICU. If the baby is doing well, the baby comes for a routine follow-up. If there is a tone abnormality or a GM abnormality, start intervention. At 18 months, sometimes you have transient tone abnormalities which could normalize. These are babies who need to be seen again at school age to assess their hand function and their academic inattention. Whereas if the tone abnormality persists, this is a baby who could likely have cerebral palsy. Now let's come to another baby. This is case 3, a newborn born 35 weeks, birth weight of 2 kg, had mild jaundice. Now the risk here was that this child's brother had syndromic autism spectrum disorder and antenatal testing was done. So there was a lot of stress and parental concern about development. When this happens, we would follow a high-risk follow-up for this child. Now, when we follow up the child, we look at screening. Now, screening tools available are parent screening tools or directly administered tools. A parent completed is a form which may be either sent to the parents prior or filled up by the parents sitting in the waiting room. There are various types of parent completed forms available, but one disadvantage of using it is that sometimes parents tend to overscore their child because they don't want the stigma of a developmental delay. At the other end, you have directly administered tools. Now, the commonest parent completed tool that is used is the age stage questionnaire, the ASQ3. This can be used till 5 years of age. So there are 19 questionnaires based on the child's age. So if you have a child who's 6 months, it's a form which is given to the parents. The form assesses the child's development in 5 domains, 6 questions for each. So it takes about 10 minutes for the parent to fill up. The questions are easy. There are visual aids if needed. After the form is filled out, we code it. Now, if we see the performance of the child, if the child's scores are in the white range, the child is doing well, needs another follow-up routine. If the child's scores are in the gray zone, we give an early intervention stimulation plan, see the child earlier. If the child's scores are in the dark zone, this is a child who needs a referral for a detailed evaluation. So a parent completed questionnaire is a brief screening tool to pick up which child needs a more detailed evaluation. The ASQ has been translated in India and some items have been culturally modified. It has a reasonably good sensitivity and a specificity. Coming to directly administered tools, these are tools which are administered in our office practice. The first thing that we look for is risk factors on history to know how we want to follow up the child. Look for feeding, growth, sleep patterns, and look for red flags for development again. Now, red flags for language. If the child is not turning to sound by 6 months, red flag. If he's not following one-step command, ghe, de, by 12 months, if he's not able to reference 5 objects, fan kute, light kute, by 15 months, if he's not able to show body parts by 2 years, red flag. If he can't do 2-step commands, ball ghe, babala de. This is a 2-step command so that's a red flag for receptive language or how the child understands language. Expressive language, if the child doesn't use gestures for need by 12 months, if the child is not babbling by 12 months, no word with meaning by 15 months, which is not the babble, it is pani or baba when he says baba, that is a red flag. If the child doesn't join words pani de by 2.5, no sentence by 3 years, mala pani de, if that's not there by 3 years, and if the child has lost language at any age, it's a red flag for language. Coming to social milestones, a baby, if he's not having a social smile by 3 months, red flag. Not orienting to his name by 9 months, red flag. If the child is not demonstrating joint attention, not looking where the mother is pointing, and not having functional play by 2 years, red flag. Even in older children, if they are not just able to understand the rules of the social game by 7, it is taken as a red flag. The red flags for self-help skills, child should be able to use a spoon by 3 years. If the child is not able, does not have daytime toilet training by 3 years, nighttime toilet training by 4 years, not able to wear a shirt and pant by 5 years, red flags for ADL, activities of daily living. Now, so when the baby came in, we have done our history where we have tried to look for red flags. Now we will administer a tool. Now, a directly administered tool is a more comprehensive tool. It takes slightly longer, but there is no ideal tool available. We can have a foreign tool. We can have a foreign tool translated, but what we tend to use are tools which are indigenous for India. Two such tools are the TDSC and the PDST. The one commonly used is TDSC. TDSC stands for Trivandrum Developmental Screening Chart. This is based on Bailey's Baroda norms. There are two charts, 0 to 3 and 3 to 6. There are items for motor and mental development. And what we do is administer items based on the child's age. The sensitivity is 66 and specificity is 78%. So that is how the chart looks. Now, if we see our baby, whom we are following up because there are concerns of development with the brother having autism. At 12 months, our baby was able to raise to sit, was able to stand, had fine prehension, was walking alone, but he was not saying two words. So if you draw a line 12 months, you administer all the items. These items are simple. They don't need an expensive kit, nor do they need any detailed intensive training. So our baby at 12 months has failed one item. Even if the child fails one item, this is a child who needs to be referred for a more detailed evaluation or developmental assessment. Now, with our baby, as we said, this child was able to hear, he was babbling, but there were no words at 12 months, which is why at 14 months, we administered a developmental assessment. Now, a developmental assessment, the common ones that we use is DASI, the Developmental Assessment Scale for Indian Infants, or the Bailey's 3. What we see here are actually toys with which we play with the baby. And as we do, we get an idea of the child's development in various domains. We get an idea of the child's strengths and weaknesses, and it helps us to plan intervention better. A DASI for all high-risk newborn babies needs to be done if the child fails a screen, and also needs to be done at 1 year and 2 years of age. At an older age, cognitive evaluations are done by WISC and Stanford Binet. Now we are going to look at an assessment here. It's important to remember this is a brief bit of the assessment. This is not the full DASI. While administering it, we are also looking for DSM-5 criteria for autism. This is just a 4-minute video. This is not the full evaluation, but this is just to give us an idea of how we play with the baby. Now here what we're doing is giving the baby cubes. The baby is, whether the baby is holding 2 cubes, whether there is midline, is the baby imitating? This baby is watching our face. He is watching to see our reaction. Now this is attempt to reach for 3 cubes. This is putting the cubes in the cup where the baby has imitated our action. Here, the brother and the grandmother are sitting to the left side of the baby. Now here we don't force the child to perform. If the child doesn't do something, we can come back and administer later. This is how he removes the cube from the cup. This baby is slightly distracted by the environment. Tower of two. Referencing people. Gesture. Looked at Ajji also. There he's pointing, vocalizing for what he wants with eye contact. Imitation of gesture. Stirring the cup with imitation. Pushing the car along. Interest in play is there. Then he's watching to see whether we have noticed what he's done. Patting the doll. Following command. Social routine. So he is imitating the gestures with good coordinated eye contact. Grasp. Attempt to scribble. Even when he scribbled, he will look to see whether we have registered it or not. There's no imitation of babble or word. That is the brother saying the words. So what on full administration of the Dasi and the DSM, what we found that this baby, he is 14 months old, was performing around 12 months. Also, when we played with the child, we found that there was little less stimulation happening, which was understandable because the mother was spending a lot of time in the academic pursuits of the older child. with this child, receptive language was age appropriate, but expressive language was slightly behind. Also, attention to task was something that we wanted to work on. So we started on DSM-5, we found that the social intent to communicate, the use of gestures to communicate was good. So this is a child where we gave a cognitive stimulation plan and continued to follow up the baby. Now, in case of children, with the increase in the incidence of autism, it becomes mandatory to screen for autism at 18 months and 24 months. The common tool used is the MChat, which is easily available on the net. This has 20 questions which assess red flags in social communication. If the child, the MChat is administered at 18 and 24 months. Some red flags on milestones for autism: if the child is not babbling by 12 months, no gestures by 12 months, no single words by 16, no joining of words, or loss of language. Now, if we administer an MChat at 18 months and the baby has scored well, mild, just repeat it at 24 months. If at 18 months, the baby had a moderate risk, we would administer the follow-up form, which is more in detail. But if the child's scores were 8 or more, we would directly refer this child for intervention. Now, coming to some red flags for behavior: if there are feeding issues, sleep issues, tantrums in an older child, difficulty concentrating, making friends, school refusal, worrying a lot, if there is primary enuresis or encopresis, these are red flags to behavior difficulties. Now, so the algorithm is the follow-up is planned as per whether the baby is low risk or high risk. If at any time the child fails a screen, refer for a more detailed assessment and start intervention at the earliest. Now, this baby that we saw at 2.5 years was using just single words. He was started on speech therapy and he's currently doing well. Now, let's look at vision. Which babies need to be screened for ROP? Babies who are less than or equal to 34 weeks, less than or equal to 2 kg, and preterm babies with sicknesses in need of cardiorespiratory support, oxygen apnea, anemia, and neonatal sepsis. When do we screen? At 4 weeks of age. And in very preterm babies less than 26 weeks, the first examination may be done at 3 weeks. Coming to red flags for vision: no smile by 3 months, not tracking and fixing onto objects, fix and follow if it's not there by 6 months, if the child holds objects too close, if the child has a nystagmus, if the child tilts his head, has a squint, and we'd also look at the pupil to look for milky appearance, not to miss a cataract. Hearing screen: the OAE needs to be done before the baby is discharged from the hospital. If it's failed, we need to repeat it at the first immunization visit. If that's failed, we would need to do an ABR. All high-risk babies from the NICU need a 2-stage screen, an OAE as well as an ABR, so that we can pick up a hearing loss 99% specific. This is not to miss an auditory neuropathy. Now, let's look at our last case, a 5-year-old boy who was referred from his school. The teacher saying he just doesn't sit down for circle time. He is hitting and pushing children. He doesn't like all the pre-writing activities, the coloring or the beading, but if you ask him something, he is able to answer. When it comes to written tasks, sometimes there are reversals in his letters and he has excessive tantrums at home. So when we probed into his history, we found that he was a premature baby, was born 1.2 kgs. There was no family history of psychiatric disorders. In his developmental history, this child skipped walking. He started walking early. He was still using both his hands by 5 years. To eat, to write, he'd use both his hands. So there is mixed laterality. In self skills, he was fussy about food, didn't like certain textures of food, started speech late. Now he's able to use sentences, and he has tantrums, hits and pushes children at home. So what could it be? It could be an attention deficit issue. It could be he need to probe at social skills, autism. Is it sensory processing? Is it developmental delay? It need to assess his hearing, or is it a combination? So red flags for ADHD in a small baby: if there are feeding issues, sensory issues, baby doesn't like being cuddled or held too close, if the child's not playing with toys, these are red flags. In early childhood, like our case number 4, running around, tantrums and language delays. In middle childhood, difficulty making friends and sustaining play, difficulties in academic work. 46% of children with ADHD are likely to have learning disabilities. So we need to keep a track on their academic performance. And in adolescent age, they could have risk-taking behaviors, academic issues, and difficulties with jobs and relations. So ADHD is a neurobehavioral disorder where there is a maladaptive level of impulsivity, reckless, premature thinking, hyperactivity, the child is fidgety, and inattention to tasks that need sustained attention. It's important that the difficulty is noticed in more than one setting. Many times parents come and say, oh, my child doesn't sit. But if the same child is sitting in school, is playing outside, then some environmental modifications need to be done at home. ADHD spans the life and can be seen in preschoolers also. So when we do developmental follow-up, generally gross motor difficulties manifest by 2 years, language difficulties manifest in the preschool age, behavior or learning problems come in the school age. So follow-up needs to be done generally till adolescence. When we are looking at general examination, we look at head size, we look at the spine, we look for minor anomalies, clues to etiology, like we have a boy here who has a papillary rash adenoma sebaceum and a white patch, Ashleigh macule, which is a marker of tuberous sclerosis. So some key questions to ask parents: is there anything your child is not doing? Is there anything your child does that concerns you? Is there anything your child used to be able to do? And is there anything other children your child's age do that are difficult for your child? So to summarize, a screen is a brief tool to identify which child needs a more detailed evaluation. As per the risk, screen the child accordingly. Screening tools can be parent completed and or directly administered tools like the TDSC. Screen for motor abnormalities in a child less than 1 year. Screen for autism at 18 months and 24 months. The aim is to refer and not defer. And as we know, early intervention betters functional outcomes. So I'd like to end by saying, help them spread their wings and soar. Thank you.
Wonderful talk, and very, very crystal clear, case-based, which we can relate to day-to-day practice. And I could see there are lots of questions. I don't know how many we'll be able to take, but as long as you don't get tired, we would ask one by one all of them.
Yes.
So the first question comes: does W seating always abnormal? And if it is there, what does it exactly indicate?
Okay, now W sitting is not always abnormal if the child W's, but if the child is able to correct it by himself, if the child is able to demonstrate other patterns of sitting, straight, long leg sitting, cross leg sitting, then it's not such a concern. But most of the times, if the baby comes to sit in a W, it might indicate increase in the tone in the adductors. So these are, because we are looking at red flags, it's a quick sign to help us identify whether we need to screen the child.
Okay, thank you. So second question is, what are the red flags that you would ask, basically tell us to remember when it comes to speech development? Like, what would be the red flags, quick red flags for speech development?
We've already covered the red flags for language, the receptive as well as the expressive. If the child is not using single words with meaning by 15 months, not gesturing for need by 1 year, not joining by 2.5, I think we've covered this.
Okay, thank you. Another question is, if we are from a rural area practicing pediatrician, and how can I get trained in Amiltison and GMA if there is no qualified person around? So would you be doing any courses, or you would be available to guide online, something like that?
Now, the GM, yes, is a tool which needs intensive training. So it cannot be just administered. It's a detailed course that needs to be done. The Amiltison, however, can be learned in it's a simple tool with correct training. The Amiltison can be taught. So yes, of course, we are available to help guide if the need arises.
Okay, good. So one of the question was, is ASQ validated in Marathi? But there is another answer given by Dr. Anjali from Bangalore, which says that it's not validated in any of the Indian languages, but she's using in 10 years. So what is your take on this?
ASQ has been validated in Hindi by Juneja et al. And it with some modifications of items. So it is relatively sensitive, available in Hindi.
Okay, good. One of the interesting question is, some parents mostly complain in second year that the child was speaking earlier, had few words, 2 words, and now he refuses to speak those words. Clinical examination is absolutely normal. And what is this? What is it we need to find out?
This is regression of speech. Now, regression of speech around 15 to 18 months can sometimes be noticed in autism, not in all children. 30% of children with autism could have regression of language around 15 to 18 months. They had those words, but they just stopped using it. We need to look at the stimulation that is happening, because sometimes the need to use that word is just not there. There has been too much electronic media exposure, especially more so in this current era. So a lot of factors need to be looked at, but one of the commonest differential diagnoses that we would need to look at is ASD.
Okay, now we have BSID4 also. So what is it that is different in BSID4 as compared to BSID3?
Okay, those details are still not available. We don't have yet training courses available for BSID4. We need to look at it maybe a few couple of months down the line. But I think the ability of BSID3 to overscore, maybe that's something that may be covered. But of course, the details are not yet available. Maybe we know better in 6 months to a year's time.
Okay, can you please explain one more time, when do you actually say that you have failed TDSC?
Okay, now TDSC, if you administer all the items on the line, if the child passes all items, the child needs to come back for a screen. If the child fails any item on the line, any item to the left or on the line, the child has failed the TDSC.
Okay, wonderful. Your take on the newer interventions like goal, activity, motor enrichment, game and learning games over traditional techniques like Bobat?
Now, the current trend for therapy has shifted from passive stretching based therapy like Bobath, and it has shifted towards active goal directed training. So as we mentioned, we are going to aim at motivating the child to perform, empowering the parent to give correct postures and combine it with muscle strengthening. Also, we have constraint induced movement therapy for hemiplegia. The child is using this hand less, so you restrain this one, the child uses it. You have bimanual therapy where you teach the child to use both hands together. So the current trend is to use active strategies. Passive strategies have been proven now not to have a great effect on motor outcomes.
Okay, good. Now, one of the very common questions that comes to everybody's mind is, we talk about early interventions, but suppose you find a child with hypotonia or hypertonia or vision or hearing problem in an ICU, what is it that we can start doing in an ICU?
Okay, now in NICU, we could start interventions in terms of providing visual stimulation. We could, for tone abnormalities, we could use correct positioning techniques. We could have what we call as developmental supportive care to have correct postures, correct feeding patterns, which could be started straight away in the NICU and then follow up with intervention at later ages.
Okay, so the list of red flags while listening to your presentation was overwhelming. So, and for a busy pediatrician, when he's doing general exam, physical exam, how do we make sure that we don't miss these red flags? Do you have any tips or any resource that you can share with us or give us?
Important to remember the key red flags. Remember the key red flags for gross motor, for language, for social, for self-help skills, and we make sure that we don't miss out on any. There is no actual resource. These red flags are basically derived from the cutoffs in the TASI.
One of the interesting questions from Dr. Rakesh is role of physiotherapy in hypotonia. What do you think about this?
Okay, now when there is hypotonia, the aim of therapy is to work more on strengthening and facilitating correct patterns for balance. A lot of times, sometimes we do see that the tone evolves and over a period of time, the hypotonia, if it's not syndromic and if there's no other neurological cause, could normalize. But these are children who may have benign congenital hypotonia, but that's a retrospective diagnosis. You have hypotonia, you need to intervene by starting strategies.
Okay, there are more questions. So would the organizer permit me to ask more questions or?
Sir, please carry on.
Would you permit us to ask more questions or you have time?
Sir, we have a lot of time, sir. It's
Okay.
basically this is a learning teaching session for all of us. So we are happy to have questions.
So the next question is, we have a baby with developmental assessment coming up for a bilirubin of 25 to 30 in the neonatal period, and there were features of kernicterus. So what is it that one needs to be very, very carefully following this child?
Now, these are babies who are at risk for hearing loss, tone abnormalities, and cognitive impairment. So this baby would need a hearing screen at the earliest. Most of these babies tend to have dystonia or tone fluctuation. So starting correct intervention at the right age. Sometimes we do supplement with a little bit of medication to help reduce the fluctuation of tone. A cognitive stimulation program needs to be started, and this baby needs to be assessed regularly as per our high risk protocol. Generally, a hearing evaluation needs to be done before 3 months, because the earlier we intervene, the better is the language performance of the child at a later age.
Great. Can you suggest some strategies for a child who has drooling of saliva and who keeps in his food in mouth for a long time? And how do we deal with this kind of situation?
Okay. It depends on the age of the child and our neuromotor evaluation. So a lot of little babies tend to have that. That is fine. But if you have an older child, a 3-year-old, 4-year-old who is drooling saliva, you are going to assess the tone, the oromotor tone. You're also going to assess the general tone. You would come up with strategies for better oromotor tone. You have brushing and other strategies that are given to the parents. Correct positioning at the time of feeding may be advisable. It's important for parents not to say to the child, don't push, because then it sort of makes the child very anxious. So one way is to teach the parents to asa bot लावला आणि पोट मिटतात. तर हे जरी शिकवलं, असं जरी केलं, the child learns to close his mouth. No medication is indicated for drooling of saliva.
Okay, so other question is, if you have a child with drooling saliva, but normal milestones otherwise, is there anything specifically one needs to look at?
We would, depends on the age of the child, we'd look at neuromotor evaluation is the generalized hypotonia, and we'd come up with an oral placement therapy program. That's it.
Okay, is there any causal association between use of mobile and speech delay in children?
Okay, now this is a very debatable question. Around 15 to 18 months, sometimes children with autism tend to lose language skills. Currently, children with the pandemic especially are spending time in indoors. Parents are working. The only thing the child is left with is the gadget. Now, when the child spends time on the gadget, there is too much visual stimulation. It's a one-way process. So the interactive play, the turn taking, the learning, the problem solving gets affected, which is why we always mention to the parents to keep the gadgets to the minimum. खाताना पण गॅजेट गाणं लावून नाही करायचं. You can do something with the child as a task rather than using gadgets. Gadgets can hamper, not only are they these are not causes for autism. These are some factors in the environment which could contribute to it.
Okay, so one of the interesting question is for general movement assessment. Do we have any cutoff of frequency of movements?
Okay, there is no.
Yeah, and sub question to that is this is from Dr. Kalyan. We have a newborn with meningitis, movement and variability in the generalized movement assessment. And can we have a cutoff on the frequency of movements? So wants to know more about this in detail.
Now, the movements are not judged by how many movements you see. It depends on the length of your video also. So it's more important to see how they are occurring rather than frequency. Frequency is not important. You can just see one movement pattern in the 30-second video and predict whether it's normal or poor repertoire. Frequency is not important.
Okay. What is the ideal age of examination and diagnosis of a child with autism spectrum disorder and ADHD?
Okay, the earliest is as early as possible. Now, a lot of times with the increase in the awareness, parents are coming up to us as early as 12 months, 15 months, picking up that the child's not doing those social things that the child should be doing. So pick it up at the earliest. Our aim is not to stick a diagnosis of autism. Our job is to figure out what are the areas we need to work on and start intervention and keep a track on development. You don't need to do a formal ADOS or an ADIR on a little baby to diagnose autism. You need to see the child, do a DSM, pick up areas which you need to work on and keep a track of development. Most of the times you find that if you have a child who at a younger age on DSM-5 had autistic features, 80% the child is likely to fulfill the diagnostic criteria on the ADOS at a later age. So start at the earliest. ADHD generally manifests when the child, of course, there are red flags at an earlier age. If the parents come up to you with it, start intervention, give them a stimulation program, teach them correct methods of handling and play and behavior modification. If the child comes to you at a little, generally they come in when they start going to preschool and the teachers start noticing, we start work at the earliest. Our job is not to stick a label. Our job is to work on bettering the attention and the language social skills.
Okay, so one of the questions that was raised by Tejas is that he wants to know in simplified form difference between physiotherapy and occupational therapy.
Okay, now physiotherapy is working on gross motor skills, muscle strength, balance, and achieving gross motor milestones. Occupational therapy is working on the function of the hands. The occupation of the hands is to play, is to learn to feed, is to learn to use my hands to dress myself, and at a later age, coloring and writing. So occupational therapy tends to work more on hand skills, fine motor skills. A part of occupational therapy is also sensory integration, where we work on sensory processing to have better integration.
Great. And perhaps the last question is, with this COVID pandemic, can you suggest any innovative ways you are doing these follow-ups now,
Yes.
considering you are not able to do assessments physically?
Yes. Now, this has been our biggest challenge for the last year and a half. What we tend to do is use video-based assessments. In case there is lockdown, the parents can't come down. So we send the parents a preset determined set of videos which they send across to us, which we evaluate beforehand. Sometimes the parents are not able to shoot them as well. So it is done while we are having our consult. We tend to re-administer the items. Of course, this is just to give us a snapshot of what we want to work on. So we are not giving a diagnosis based on our online assessment. We are figuring out areas that we want to work on. We start intervention, but we do aim at seeing this child at least within the next 3 months, at least once. Regular babies who've been coming to us for years, and we know those babies are easy to follow up on online because we know what they're capable of doing and we can monitor their improvements in the videos.
Okay, so Nanavati madam has a comment and a question. So she was very happy to listen to your talk. She thoroughly enjoyed it.
Thank you.
And she wants to know whether the Darcy scale has been revised.
Ma'am, Dasi revisions had started in our center around 1.5 years ago, but with the COVID pandemic, now things are on hold. Probably when things get better, we will have our normal babies start coming in for standardization. So probably it's the COVID which has led to the delay in our revision of Dasi.
Yeah, Archana, am I audible? Yeah.
Yes, madam.
Yeah.
Yes, ma'am.
It was a very nice talk and, thoroughly enjoyed. And I think I should congratulate, Sandeep and team for organizing this talk because this is much needed, topic, even for, not only for, even for the DM student, this information is very, very important. So what I want to know, since, the Dasi is, the means Baroda norms with indigenous kits and indigenous instructions is Dasi. But basically it was in 1970 or probably in 1980. Now after 1980, we have almost, say about 3 to 4 decades old. So in these 3 to 4 decades, the whole generation has, it changed, right? So one of the sort of limitation or something of Dasi is that it's not revised in a recent year. While our BSID, not ours, but the BSID is, you have BSID 2 and then we are trained in BSID 3. So in that context, I wanted to know how do we look at Dasi?
Ma'am, you're right. Meaning in terms of the limitation, yes, it's the biggest limitation because some of the items, even our pictures, some of the pictures our children can't identify because they are line diagrams. So yes, definitely that is a limitation. Also with the Flynn effect, children tend to score better cognitively over the years. So revision is definitely mandated. But if we are trained for a Baylis, what we tend to do in the Baylis takes slightly longer to administer, but if we are trained in both and we feel that we are better equipped at identifying or administering a tool, I tend to do the BSID 3 currently rather than use a Dasi. Only if it's for a quick evaluation to start intervention, I tend to use the Dasi. But if you're say looking at the developmental profile of a child with Down syndrome come for follow-up, I would do the Baylis.
Okay. And other comment is, we do Ameltison, but we also do Infanib. So do you have any experience on Infanib?
No, ma'am. No.
Okay.
I am GM trained. I use Ameltison at the later age.
Okay, because Infanib as a scale also is basically derived from the French angles of, Ameltison scale. And it is relatively little more objective. It has got 20 points and you can give them this. So, few years back, we are doing Ameltison. As far as neuromotor is concerned, we do Ameltison and Infanib.
Right.
And mostly we were doing Dasi. Then subsequently we stopped doing Dasi and now we are doing BSID 3. And of course, it is done by the residents who are trained. We used to send them initially for training, and then they used to, they have also come to, earlier batches have come to Pune, got it trained from Dr. Chaudhary. But so Infanib is also one of the technique. But yeah, so that's what I wanted to say. But very nice, really enjoyed, and congratulations. Great.
Thank you so much.
So Thank you, Archana, for wonderful talk. And for Sandeep, there are messages from PG students. They want more of these talks. They want more of this online training.
Yes, sir.
And they want all the help from you to organize this in future. And thank you for giving me the opportunity to moderate the session.
So thank you so much, sir. Thank you, Nanati madam. Thank you, Archana. It was wonderful on behalf of the state NNF. We look forward to having many more such sessions in days to come. And all the delegates, thank you very much. Next week we will have the ENRP workshop. So for that, I'll just send the message for in the group. So thank you so much. Thank you, sir.
Thank you. Bye.
Bye bye.